Mr. Lowry has a quaint way of putting together his lecture series. He first circulates department chairmen, asks them if they won't please ask among their summer teaching people and others if can't give him some help. And you volunteer like a fool, and he follows up with a memorandum asking you to provide somebody to introduce you. We permit being recorded, and all that business. I'm Jerry Shakeshaft. I try to teach political theory here, and I'm up here, I suppose, by virtue of a long, now withering career on the side in health matters, beginning with 10 years of service in the Department of Health, Education, and Welfare in the 50s, primarily in the Hill-Burton program, and more recent service in the Iowa Comprehensive Health Planning Council, in which I believe I've chaired now 3 committees, the Exceptions Board for the health industry in this state, Phase 2 of the Economic Stabilization Program, 1 term of service on the board of the Iowa Regional Medical Program, and other related pursuits. The subject which I grabbed bears some broad-scale characteristics which make it extremely difficult, if not impossible, to discuss in even the broadest strokes in a short time, assuming I were even capable of doing it. In the first place, it is full of contradictions and inadequate information, conflicting values, and just great quantities of sheer argument. For example, the title of the remarks, which I sent to my chairman and he sent on to Jim, "The Crisis in Healthcare," is taken from the President's health message of 1970. It was President Nixon who used the term crisis, and therefore I feel safe in using it. And yet many members of the medical profession stoutly maintain that there is no crisis at all, that care given in the United States now is totally adequate, or nearly so. Secondly, another example of the contradictions in the business is that the most legislative noise in the past 2 years has been made over the concept of the Health Maintenance Organization, a concept which is the brainchild of an interdisciplinary think tank in Minneapolis, which was embraced by the Nixon administration as a way to control the galloping costs of Medicare. But it has now been fastened to and hitched to by health insurers, both commercial and blue, as a way to participate in the financial fruits and the financial mechanisms of national health insurance, which anybody or almost everybody agrees is down the road. It has been oversold as to what it will do and has been considered by some people, including your speaker, as a rejuggling of the payment mechanism for the middle class, with little prospective change for the poor, the aged, the near poor, and the currently uninsurable among young adults. Another contradiction exists in whether or not HMOs will indulge in prevention. They are being sold on the argument that they will provide regular medical examinations, regular medical care, because it is prepaid. And yet some recent critical studies have indicated that in Kaiser Permanente and in other long-standing HMOs like Group Health in Washington, some of the standard conditions that afflict people after 20 years their morbidity has been affected not at all. Another contradiction rages over health personnel and the adequacy both of facilities and personnel. There are wild swinging arguments on the federal role and equal arguments on the current adequacy of research efforts. A second complicating factor is the horrendous volume of literature in the business, which is almost more than anybody can cope with. There are 17 full schools of public health in the United States now, and departments of social and preventive medicine attached to most medical schools, all with sizable libraries. We do not begin to take even, I would say, 30% of the range of available literature in the field at the library here. And with apologies to my colleagues in political science who are in the room, I'd like to read you something written in 1961 by two of the most astute observers of the field, Anna and Herman Summers at Princeton, when they were writing on the field, wrote their book, Doctors, Patients, and Health Insurance, and this is from the foreword. 6 years ago, the Summerses write, we opened our book, Workmen's Compensation, by remarking, quote, we had to write this book in order to learn what had happened to workmen's compensation in the United States. There appeared to be no other way. One of the most remarkable facts about the oldest of our Social Security programs, namely workmen's compensation, is the lack of available information about it. Then returning to their foreword in 1961, they go on. This cannot be said of our present subject. The past decade has witnessed a striking and exciting upsurge of activity and unprecedented expansion of general and professional interest in medical care. We have experienced a veritable flood of reports, surveys, exposés, proposals, and recommendations. The quantity of data is truly overwhelming, and we may be forgiven if we say that with some feeling. That was in 1961, written by two people without children, who have both acknowledged the indispensable help of a housekeeper and two typists in everything they have written since. 12 years since, it is worse in almost geometric proportions. So I must apologize to Jim and to some of you. I normally spend my summers catching up, and I'm actively writing in this business in a limited area of it this summer. But the summer isn't over yet, and I'm sure I will not even be remotely caught up by August. A third complicating factor is that everybody tends to look at health problems from his own peculiar perspective, be it the issue of cost, medical conditions, one's last hospital bill, Aunt Maud's gallbladder, or the now almost inevitable problems of aging which are hitting every family. And to conceptualize these things for a general audience gets a bit difficult, I have discovered. A fourth complicating factor is the agonizing interrelatedness of the issues. In times past, there's been some tendency to put the problems in boxes. But today, the talk is about systems as a whole, and a lot of younger observers tend to think that this talk of systems as a whole is something new. But a little reflection leads to the conclusion that such thought is not new. From the time of the monumental work of the Committee on Costs of Medical Care, appointed by two Republican administrations, and which sat from 1927 to 1932, to the present profusion of congressional and state legislation hearings and literature on the healthcare crisis, there has been an interrelatedness among many elements of the system. Four elements perhaps predominate and are as mutually dependent as the legs of a chair. First, the organization of the delivery of medical care. Second, payment mechanisms for the payment of medical and institutional care. Third, the availability of competent personnel. And finally, the planning, financing, and availability of facilities. There was a time when the sheer absence of facilities caused us to think of that problem in a vacuum. But even that tendency, which characterized the early years of the Hill-Burton program, was short-lived, and during that period itself, no thinking person was fooled by it. The consideration of facilities has never, in a vacuum, has never been realistic. Conversely, limiting discussions of delivery systems to payment and the organization of medical care, to the exclusion of availability of personnel and the planning of facilities, is equally unrealistic. there is considerable evidence to support the thesis of Ann Summers that the hospital or related institution should stand at the center of the planning for the healthcare system of the future. Having given this general backdrop, then I think there is really no need to apologize if one outside observer misses here and there in some of the significant trends which have affected the past generation. The trends of the past generation have been so thoroughly worked over in the literature that they really need little explication. First, in the arrangement of facilities, there has been no system at all, but a super non-system containing a polyglot of arrangements. Significant numbers of our population receive care in a military system, others as types of direct beneficiaries of other types of federal institutions. Then there are those facilities built by and serving industrial occupational groups. There are the state and local publicly supported disease or condition-oriented facilities. There appears to be a growing number of facilities serving exclusively prepaid subscribers of medical care plans, numbering last month just over 9 million in the United States. And then there is, of course, the broad and diverse range of facilities serving the general public. You know the range. This non-system has characterized both the nation and this state through all of its history. As a matter of fact, we are this year observing a rather peculiar anniversary in the medical and hospital world, which is the first public lamentation about duplication of facilities ever presented to a convention of the American Hospital Association. What then are the issues? Certainly the one which I suppose predominates in the public mind at the present time is the issue of costs. And as a backdrop, I thought you might like to know, again with apologies to Bob and Ross, about the magnitude of the system we're discussing. And I thought I would read to you an example or two of the sheer size of the hospital system in this country alone, not to mention all the doctors' offices, all the outpatient care institutions of other types. Last year, the percentage of the American hospital system take from the gross national product exceeded 7% and was still rising. That's a rather gross figure in nature, but listen to some of this. In 1969, hospitals in the United States had expenses which were 2.25 times as large as all operating expenses of providing domestic telephone service, 3 times as large as the U.S. Postal Service, 10 times as large as all network and local television systems, 3.5 times as large as all scheduled domestic airlines. On the assets side, in 1970, the value of the American hospital plant was only 3% smaller than the highest traditionally capitalized American industry, the American Railroad. It was only 64% as large in total assets as the Bell system, but it was 1.5 times larger, Professor Lowry, than the total iron and steel manufacturing industry in the United States. In 1970, hospitals had more employees than the federal civilian force, 5 times as many as the railroads, 10 times as many as the airlines. In the 1964 Census of Agriculture, if you compare it to that, in 1964, there were 61% as many hospital employees as there were farm operators in the United States, and I dare say that they have passed farm operators by now. Just 2 years ago in Iowa, in all but 4 communities, the hospital payroll was the largest payroll in every city having a hospital. Now, what is the substance of the cost issue? From 1950 to the imposition of Phase 2 economic controls in October of 1971, the cost of hospital care outstripped every item in the domestic budget in its rate of growth, that is, the cost of health care. The expansion was especially marked in hospitals in the 50s, in which they more than doubled in the 50s, and then in the 60s, they again went up by 3 times. Medical care started to rise significantly after 1969. The index of total health care costs in the nation rose 63% in the decade of the 60s. The largest single component of this occurred in hospital room rates. In all fairness, I think it should be pointed out that the largest single cause of this increase was the coverage of hospital employees under federal minimum wage legislation in 1968. And the increase actually slowed down to some degree toward the end of the 60s and into the early 70s. Second manifestation of the crisis appears in the shortage of manpower, primarily physicians. I am not going to elaborate on this except to say 2 or 3 things. First, the problem of manpower adequacy cannot be considered in a vacuum or in the absence of considerations of standards of care. A frequent example, which we hear and see in the daily press all the time, is the absence of adequate, decent initial contact points for primary medical care, meaning, to use an old term, the family doctor, or the contact point for the family, an entry point into the system. Just last night I heard Goodman Ace redefine the term family doctor from the man who at the turn of the century sat at the bedside with a turpentine stoop and a bottle of aspirin, holding the hand of the patient all night long, and then eating a few cookies left casually on the bedside beside him, to the definition of the family doctor today as the doctor who takes his family for 6 weeks to Paris, Athens, Rome, and Naples. But again, the point here is that the standards and considerations of the whole spectrum permeate such considerations. What is an appropriate contact point for rural Iowa? What is an appropriate contact point for the inner city? And in Iowa, you are thrown back on a whole broad range of planning considerations as well as standards. Dr. John McQueen from Iowa, Associate Dean of the Medical School at Iowa City, is, as some of you know, currently peddling a sort of platonic ideal plan for the state of Iowa, which he knows will never be effectuated exactly as he has written it. But in the effort to get people to think about standards, the family doctor, if he ever did exist, is a dead issue. What can we substitute in its place, given the nature of medical training today? This issue has brought up also discussion of paramedics, which gets one immediate, meaning a non-physician, a retrained, usually medical corps man, who works under the supervision of a physician in a remote area, takes histories, bloods, and other minimal matters in the interest of holding down the pressure on the doctor. But this gets one immediately into problems of the legal liability of physicians, the proximity and the desirable proximity of supervising physicians, and actually into the non-scientific emotional expectations of the patient vis-a-vis his physician. You can also not consider the absence of personnel or physicians in the absence of consideration of very broad socioeconomic and cultural factors that affect where they locate and how they want to practice, and you cannot consider it in the absence of consideration of what effective physician training is in the latter quarter of the 20th century. A third evidence of the crisis is the maldistribution of facilities. For example, in last year, Iowa's state plan for hospital and medical facilities showed that Iowa had 28% more general hospital beds than it needed under current Hill-Burton planning standards, although the surplus, 28% more facilities, although the surplus in beds was only 10%. On the other hand, that plan shows a deficit in long-term care facilities of 50%. Nobody swallows in toto a state Hill-Burton agency's figures anymore, least of all the agencies themselves. But there is no gainsaying that the alignment of facilities is out of touch with need, and these data do not speak to such matters as home care. Fourth, we are living with a technology which has outstripped the architectural and functional capacity of facilities to render first-class modern care. Iowa has been typical of this national problem too. In the first 24 years of the Hill-Burton operation in this state, for example, 185 projects were approved, which assisted 108 facilities. Of these 185 projects, 90 were not new facilities or additions at all. They were modernizations or replacements of obsolete facilities. And those of you who may have followed the enmeshment of Hill-Burton in the Watergate crisis know that the major argument being advanced for Hill-Burton, which is the federal grant program for community hospital construction, today, against the president's desire to eliminate it, has been that the rate of obsolescence of facilities poses a much more severe problem than the actual absence of the facility did 20 years ago. I disagree with that, but it is being quite seriously urged. Fifth, manifestation of the crisis. A continued orientation of our approaches to delivery, at least in the popular mind, toward the treatment of episodic illness, to the neglect of any systematic approach to prevention. Too much of the nation tends to think of the current crisis in terms of physician shortages only, without consideration of prevention. I would like to return to that in some concluding remarks, if I may. Sixth, manifestation. A two-class system of health care, which often results in inferior care or no care for the poor and the near poor in two primary locations, the inner city and the rural area. The concrete manifestations of this problem are probably no worse than they were in the 20s or 30s, but certainly they have become more visible. Seventh manifestation is the simple and plain lack of availability of medical care, even for those with some ability or considerable ability to pay. A problem which is prevalent in considerable parts of the nation and which has been aggravated in Iowa by the movement from the land. I talk here about people who simply do not know where to go or who are unable to gain some form of health insurance by virtue of pre-existing medical conditions. The eighth manifestation is a widespread diffusion and confusion in the bewildering array of public and voluntary health programs, a veritable mess of overlapping and lack of coordination into which is poured annually a staggering sum of money, providing at best fragmented treatment of episodic illness. Some month throw all the come-ons and requests for money you get from health organizations in a cigar box and look at them at the end of the month. If you are even remotely on the sucker lists I am on, you will find that it is an impressive gang of requests. These people spend money as well as massive monies being spent primarily by the federal government in research and treatment programs, and there is very little coordination in it all. Finally, the final manifestation I will mention is an inadequate planning job in all jurisdictions, resulting in unevenly distributed and non-comprehensive services. I have borrowed this broad paraphrase from the National Health Forum of 1970 as being the broad characteristics of the healthcare crisis, but there is nothing original about the language, nor was there anything original about the language presented there. It appears over and over again in the literature and comes readily to hand with anybody who's been working with the problem. Within that crisis, that forum also isolated the characteristics of what it called a crisis within a crisis. That crisis centers on the paucity and indignity of care for the poor and the near poor. I seem to have lost a page here. Well, bear with me just a minute. Lost a good deal more than that, and we will go on. A question can rise, then what have we done about it? And I would like to throw out the hypothesis that we have done a great deal more, probably, than we think we have done, but sluggishly, with gradual recognitions through the 50s, and a catching up in such matters as long-term care, and certainly the heightened, the greatest response we have put forth yet has been Medicare, which, I regret to say, carried a companion feature for the near poor and the poor, which has been badly eroded. It has been badly eroded in Title 19 of the Social Security Act, called Medicaid, because, frankly, it has been so blasted expensive that state treasuries have not faced up to the problem of providing adequate care for the poor. Last year, Congress followed along by eliminating a requirement that every state should have a Medicaid plan by 1976, and the states are now on their own, held only to a minimum program by federal law, which would require them to cover all the old categorical welfare recipients, the ADC, the blind, the old age assistance recipients, which come to really a handful of the need for federal underwriting of the care which is needed. Where then are we today? The current push is toward the reorganization of delivery systems, primarily toward prepaid full service for enrolled population groups. This has been the Nixon push and has been the push of several other significant groups, with the exception of the AMA. The forms of action in the federal government have taken the form of the authorization of Medicare payments through health maintenance organizations, as effected in last year's Social Security amendments, and in assorted bills for federal startup money, the leading one being current Senate Bill 14, which came out of committee about 10 days ago, or a little longer than 2 weeks, I guess, and is due to be voted on by the Senate shortly. It has taken the form in the states of authorizing legislation for HMOs, health maintenance organizations. The bill has passed in Iowa, which will simply amend the corporate acts of Iowa to permit an insurer, fundamentally, or any other corporation to get into this business. I will talk about the type of business in a minute. It bears the features of the establishment of a responsible corporation, financially and legally, hooked up with group practices of physicians who will provide service of varying types, depending upon the corporation, the geography, and the availability of personnel, on a prepaid basis for a specific enrolled group. Let us take hypothetically the city of Ames, and it has been discussed in the city of Ames. Bankers Life would contract with the McFarland Clinic for certain capitation payments to physicians there, based upon the number of people it might enroll in the city of Ames. In the package would come full hospital care and full medical care, insofar as the McFarland Clinic had the resources to provide. The general estimate nationally for a family of 4 people is somewhere between $54 and $60 a month. Everything in the package, excluding psychiatry and dentistry. This, I think, may well come here in time. The leading stumbling block up to now, as I understand it, I'm not privy to all the discussions, has been the reluctance of the faculty committee involved to hear all the discussion about the matter. A second response that is going on at the moment in Congress, oddly, is an increased concern over emergency service, which I can only interpret as a response to the increased scarcity of personnel and facilities in rural areas and in areas in cities considerably removed or uncovered by existing service. Third, there has been a massive and intense re-examination in the federal government in the past year and a half of some dozen existing health programs with the recommendation that they be eliminated. Bill Burton, the regional medical programs, some programs in medical education, numbering about 12 in all. I have personally been impressed by the degree of intelligence and selectivity with which this present administration has gone about this business, in spite of some of the chest pounding that has gone on by the health angels in Congress. They are now, of course, like everything else, caught up in Watergate. And the present omnibus bill, which would restore all 12 of them beyond their, or continue them beyond their expiration date at the end of this month, and normally they carry authorizations of 3 years or 4, that bill will probably now pass. There is fourth, an increased concern for regionalization of services in federal support of research and federal financing of some regional health maintenance organization arrangements. This has carried with it an enormous emphasis on planning and in the training of people to perform this kind of planning, that being they're being very short in supply. There is fifth, permeating all the literature and all the discussion on the Hill and in the private world, a great deal of worry and conflict over the ultimate arrangement of service and the eventual form of national health insurance. One of the leading criticisms of the HMO concept is fundamentally political. That the people who are establishing them, and there are now, as I said, just over 9 million people covered, Kaiser on the West Coast being the largest, that these people are rushing into the business mainly to get their foot in the door to catch the financial ball on the payment mechanisms when it is ultimately thrown from Washington sometime after 1976. We are definitely, I think, headed for national health insurance. I don't believe anybody would disagree with that. The forms it might take vary by the particular orientation and frame of mind of the proposer. The American Hospital Association, in company with other interests, have in Congress, under the sponsorship of Congressman Ullman of the Ways and Means Committee, representative from Oregon, a bill which would authorize federal payment and underwriting of large health care corporations, which would mandatorily cover everybody in a city the size of Chicago or Des Moines or Minneapolis under perhaps 3 or 4 different types of plans, but to which all hospitals would be parties and all physicians would be free to contract. The Aetna Life and Casualty Fundamental, representing the larger insurers, has a stair-step, phased proposition, which would start with immediate federal underwriting of the poor and move on through a number of devices to increase available manpower available facilities, and eventually winding up in 8 or 10 years with full federal underwriting of all persons in the society. The AMA resists them all. Its particular program, MediCredit, has now been fairly heavily discredited, would provide tax incentives for the carrying of commercial health insurance, fundamentally with some other features, and beefed up medical education. There is a sixth sixth response we are making at the moment is a wide range of proposals and fights centering on the concentration with holding down federal and state budgets versus, on the other side, response to specific disease programs. Here, or disease problems. Here, the leading example is a current fight between the Nixon administration and the health professionals on the other side over the degree of funding of mental health centers throughout the country. In conclusion to this discussion, and I hope there might be some that might stimulate some discussion, I think it is my own feeling that in both public policy and with respect to how the private person should look at his own medical needs, the 70s may well be the decade of prevention. I think the article by Dr. Lewis Thomas, Dean of the Yale Medical School, which appeared in the Saturday Review, December 23rd of last year, probably ought to be required reading for all undergraduates considering a health profession and for a great many patients as well. Dr. Thomas points out that a high degree of the enormous cost of medical care today results from an absence of technology, absence of know-how on the part of the physician. That the physician traditionally has had three functions. One is to prevent to the degree he can. Secondly, to cure. And third, to provide tender, loving care. He is hampered in all three in the modern state of things, but he is particularly hampered in the major remaining disease entities by an absence of preventive and simple curative devices. Dr. Thomas points out, for instance, that the cost of treating a polio case has declined enormously on a unit basis because of the Salk vaccine. That the day that we find a way to keep the coronary artery from clogging up will be the day we eliminate the artificial machines for hearts and do away with most of the intensive care units. And that day will come. Meanwhile, we indulge in extremely expensive arrangements which can only be solved at the moment by sensible preventive living by the patient himself and by research. And that Dr. John Knowles, who is now with the Rockefeller Foundation and no longer with Massachusetts General, has flatly stated that he thinks the 70s will be the decade of prevention. That probably we should greatly enhance and beef up the expenditures being made for medical research. And again, Mr. Nixon likes to make a great deal of noise about having troubled research funds in heart, cancer, and stroke, and other research funds. I don't know what the answer will be beyond 1976. There is one other political facet of this that I would like to point out before finishing. It's very interesting that in the discussion of Senator Kennedy's proposals for national health insurance, which would be fundamentally a direct federally administered thing, and the Aetna Life proposals, the AMA proposals, and the American Hospital Association, and the unions who are in company with Senator Kennedy. all totaling up last session some 44 major bills, providing for national health insurance in some form. The discussion has had a subtle undertone to it, and that is that the present system of fee for service must in some way be accommodated. Either on a prepaid basis, by which capitation payments are made to the physician, or that the fee for service basis certainly should not be eliminated. The HMO proposal does not fundamentally alter in a serious way, in my opinion, the physician's financial relationship to his practice and to his patients. And it is interesting to me because it has almost foreclosed, it seems, any discussion of a national health service as such. There has been a fairly clever blocking out of serious discussion of whatever might have been learned from Scandinavia, from the British system, in accommodating the groups who are already in the action in the United States. I am not saying that it is that such a system is necessarily desirable or a national health service. I am, and I'm not sure I endorse it myself, but I am saying that I think the American people at least are entitled to a discussion of the issue, given the galloping costs and care and the list of horribles that I have read here. I'll be glad to try to field any questions that may be here, Jim. I don't know. I lost 2 or 3 pages, I admit it, but that's probably no great loss.
I usually want to start with one. It seems that one could draw some parallels and some distinctions between health care and educational care, both being things that the mass of the population needs to have or wants to have to varying degrees. They're handled in rather radically different ways presently, the organization of the provision of this service. Would you have any comment on the possible implications of one experience with regard to what might be done in the other?
That's been commented on. At first blush, one conclusion you can draw, I think, is that education has been democratized much more rapidly than the health system. I've made the remark in comments around the state, which I don't get out around much anymore, that there, at least a couple of years ago, were some indications that the kinds of tensions that higher education went through in the 60s in its democratization, meaning the pressure to reduce standards and to accommodate a much wider range of interests, was probably going to hit the health industry in its own peculiar ways in the 70s. That there would be pressure for the reduction of standards of care in the health industry, in such things as paramedics, family practice physicians. I'm not sure that's a reduction of standards, but it's a step back from the high degree of concentration and specialization we've had, and wider spread payment techniques. Well, some of that is coming, I think, and probably, but I'm not sure that it will get here quite as rapidly as some of us thought. But sooner or later, I think we may have, unless we just start arbitrarily ordering physicians and nurses and other people around, we may have a reduction of standards of care.
Well, I think maybe ask the question is one
We're going to have public payment as we do.
in education, somewhat dual system still operating, and the basic educational service is considered a public obligation to provide through grade school and high school at least, and perhaps on beyond into higher education with a limited degree. And at some point, however, well, along with that, there's a possibility of people who can paying for private to supply educational services. The private school does run clear down for those who want it and can afford it. And then when one gets into higher education, of course, there's a rather dual system, or mixed up system in operation. Do you foresee any chance of this sort of
Yeah.
thing evolving in the medical field?
I'm glad you brought it up, and it's something I probably should have devoted the whole talk to. There's been a great deal of talk, rhetorical kind of talk, actually the last 9 years, it was first used about the right to care. The phrase was first used, so far as I know, by Marion Folsom, former secretary of HEW, in a report he wrote for Governor Rockefeller in 1964 on what the people of New York needed, in which he flatly stated exactly that proposition. There is a right to basic care on the part of every citizen of the United States, and the state should pay for it, and or see that it's paid for in some way. Now beyond that, then you get into, I think, a different bag of tricks, where you might be able to differentiate higher education on the basis of ability, not just ability to pay, but sheer innate ability, differential talent. I have difficulty seeing such stratification in the rendering of medical care. Does everybody deserve, and you get into some very nice problems. Does everybody deserve a Ford or a Cadillac? Should Emmitsburg, Iowa have a level of care the equivalent of Mayo? Now the courts have had a great deal to say about this, I'm interested, including the Iowa Supreme Court, where the doctrine used to be, the traditional hospital doctrine at least, that the care had to be rendered in an institution, had to be commensurate with the accepted level of care in the community. The doctrine in Iowa has been for 3 years, following a galloping surge of doctrines across the country, that the standard of care shall now be for the state as a whole, and if it is not in some particular hospital, the hospital is liable to sue. Meaning that Boone has to have a level of service the equivalent of Iowa City, really. And this has been accompanied by some other doctrines about the hospital's liability for the physician's performance in there, which is also totally new. So I think we are getting to a point in medicine where it's going to be a first-rate math department for everybody, which is going to be hard as hell to provide. Yeah.
Isn't there already evidence that the reduction of standards and using paraprofessionals and provide medical services, that in fact that's perpetuated the double standard of medicine for those who can pay and those who
Yeah, I
can't?
think so.
And that in fact reducing the standards means reducing the standards for the poor.
Now, where paramedics are used, so far it's been a reduction of standards for the remote. They may be poor, they may not be poor. Generally they're for the poor, yes, because the rich are going to continue to go where better care. Yes?
It would be improper, would it not, to presume that numbers of specialists available in an institution can be compared with the level of quality of care in the institution. That is not necessarily true, is it? And is this not one of the myths that...
I'm not sure I understand it, but...
It is incorrect, is it not, to presume or to foster the idea that numbers of specialists connote quality of care. Paraprofessionals would not necessarily devalue or decrease the level of the quality of care, and in many instances might in fact enhance that level of quality.
This, again, I wish I'd said something about, the very definition of quality has an enormous number of factors in it. A paramedic, there's one paramedic experimental program underway in Iowa, to my knowledge, right now, down in Atlantic. We're 11 miles from town, there's an outpost. They're hitched up by telephone, they're hitched up by closed circuit TV. They have access to the physicians in this group at any time. Now, for those people out in that community, you can take you can adopt the argument, and it makes sense, that something is better than nothing, particularly that kind of arrangement, to have it at hand. And that is an increase in quality. But I don't think anybody would be prepared to say that the level of care in Atlantic is probably of the level that it is in Iowa City or in Ames, where specialists are located. But all I think we're saying is that a definition of quality is a terribly elusive matter. Yeah.
Another question closely related to that, one should not presume that that new legislation and new policies would dictate the same kinds of service in all hospitals or all areas of the state, but only the same level of competence in services rendered. Is that not true? Boone is not required to offer the same range of services, but only that the services that are rendered in Boone should be of a quality level comparable to the rendering of those services in Des Moines or in Ames.
Very, very tough problem, particularly, and I'm not prepared to say one way or the other, particularly when related to another wave of legislation that's going across the country, which I specifically avoided in this talk because I'm writing on it. The current trend is to franchise, grant exclusive rights to operation to facilities in limited areas, although the patient is free to go over where he wants to. And it is a very interesting problem as to whether the availability of service in a given facility has to be increased. Let me give you an example. Many hospitals in the United States will not accept active pulmonary tuberculosis. They will not accept alcoholics, many of them, and they will, in some instances, will not accept other disease conditions. Also, many hospitals are not equipped to accept certain types of routine things. Does the mantle of public approval, which descends on them either by specific legislation in that regard or by recognition under certain payment programs, impose upon them any obligation to increase their services? The prevailing body of law is that it does not. I wouldn't be too sure how long it will hold up, particularly when the U.S. Public Health Service itself, for instance, in the realm of pulmonary tuberculosis, is openly and strongly advocating the treatment even of the most active tuberculosis in the community. Same with psychiatric conditions. No, but the standard, the range of services, I think probably the courts would have to recognize this in the long run. It is just absurd to think that you're going to have a heart surgeon in Boone or in a number of other communities. The quality matter. So the range of service, I think that this would be recognized unless particular types of statutes impose exclusivity upon facilities, which may make them expand to some degree. As for quality, the galloping legal doctrine is that it must be commensurate with the quality of the state as a whole, which would mean that Boone has to be up to the level of the rest of the state. I frankly look for hospital closings in this state particularly, in the next few years under this doctrine. Yeah.
How much of the increased cost of healthcare, particularly in hospitals, has to do directly with providing services to patients, and how much of it has to do with administrative costs and research?
There's another one of them. 80% is, let's look at it first of the objects where it goes. 80% is in personnel. As you get in larger cities, I was reading the Washington Post series last October on the Washington Medical Center the other night. Internship and residency programs and nurses training programs can consume up to about 10% of the average patient's hospital bill. I might say in passing that 10 years ago, accounting arrangements and accountability in hospitals were simply horrible. They couldn't tell you in many instances. And one of the dramatic developments inside the hospital has been the increased emphasis on accountability. This is partly under the stimulus of the federal government and partly under their own initiative. Up to 10%, perhaps in some instances 15% goes into desirable community overhead. Let me say in this context that this is one of the reasons, particularly since Medicare, that proprietary hospitals have come back in vogue, particularly chain proprietaries. The Holiday Inns are now in the business. The Ramada Inns are in the business. Medi-Centers in Memphis. This wave of proprietary chains. And they are able to cut the rates, particularly in long-term care, and to compete vigorously with community hospitals because of mass purchasing techniques which they have developed in the hotel business and in the food business or somewhere else. And secondly, because they do not provide any community service in the sense of free care, training for nurses, interns, anybody else, and these other so-called overhead items. Now, as for excess fat in budgets in the form of administration, I simply can't tell you.
Well, I was thinking, I saw the figures recently, the cost of the Health and Hospitals Corporation in New York City, and the amount, tremendous amounts of money that went for administration. And there's a scandal now that had nothing to do with delivering patient services.
I haven't seen it, I just can't help it. I must say, every hospital meeting I go to, I'm amazed at the time these guys seem, and the money they seem to have from travel and meeting attendance. I mean, that may be just picky on my part.
Well, I think it's significant, using the analogy of education, that there's just no hesitation in talking about healthcare as a business.
Oh, no. No, it is.
And, you get a lot of flack if you started talking about public education as a business. Although probably maybe would argue about it, but the difference in attitude, I think, is.
Professor Wessel?
You said the estimated cost of HMO is anywhere between $50 and $60 a month, something like that.
The family of four.
I was surprised, I was up in Winnipeg and they told me that their provincial health insurance has been last year $9 a month. It covered everything but ambulance calls and chief.
One person.
So that was for family four, the $36. And I said, you must fix fees then. He said, no, they aren't, they're going up.
It's a subsidized system, however. That does not cover.
Is that an accounting cost, Bob, or?
This is the cost of the insured, $9. I don't know who pays the rest.
No, they have either federal and or provincial contributions toward that kind of system. And they're faced with many of the same problems our system is in terms of loss of